Okay. Hi, guys, everybody. This is a good afternoon from Las Robles Hospital. And we are honored to be presenting the last case of this pilot session of MedStream 360. We have a very challenging case, but before we start the case, and we're going to do everything. I'm actually going to first introduce the team. We have on the other side of the room, actually, let me start from here. Marwa is actually a first-year cardiology fellow. She just started cardiology, but she wants to do mitrals. Okay, that's great. She's in a cath lab rotation. You have Andrew Gabriel. Andrew Gabriel is a cardiac anesthesiologist and an outstanding cardiac imager. And actually, I want to take this opportunity to show you, even if we can't get the case completely, to show you some amazing imaging, both for mitral and tricuspid. Thanks for being here with us. Okay. We have Jose, Sheena on from nursing over here. You have Sophia hiding somewhere in the corner. You have Crystal, who's upset with me, but we made up. And we have Gabe Oreda from the Gabe and Colleen, the two RTs who are going to help out in the case. So with that, I actually want to introduce this case. And can you show the slides, please? So next slide. Press next. Hit next. Yeah. Yes, good. Next. So this is a very, no, go back, please. Okay, so this is an 86-year-old lady who's basically in class 4 heart failure, predominantly right and also left for the last 6 months. She's had multiple admissions, and she's now in the hospital for the last 2 weeks, and she cannot be sent home. And she basically comes in with gross right heart failure, left heart failure. We diuresis that she gets better. We thought she has severe tricuspid regurg. She has MR. And today we decided that we're going to treat her off-label because she was never approved for any studies. She has a thoracentesis. Her coronary angiogram shows she has occluded right. She has no significant LV disease. Her echo shows the EF is 42%, severe TR, only moderate TR, MR, and RV systolic pressure was 50. And then I diuresed her, and then her RA pressures remained elevated, but her PA pressures have dropped. And the next slide. And this shows her angiogram done a few days ago where the right coronary artery is occluded, the left coronary artery is patent. Next slide. And this is just, next slide, please. Next slide, Claire. And this just shows you one picture of the tricuspid regurgitation, which is severe. But I'm going to show you the imaging live. So I'm going to ask Gabriel to show some of the images that he's taken. So now we can switch over to live transesophageal echo. So I'm going to take access in the air. So can you show echo live? Yeah, that's okay. They'll take care of that. So Pedro, can you show echo live, please? Echo's not going. Can you? Yeah, okay, good. So that's the images on the echo. You can see over here, LV function looks down, and we actually came in doing this thinking of the tricuspid. Then as we went, can you show some images? And then as you went down, yes. Why don't you go through the images? Right? And when he did, which was not there before, right? And when he did a T about a few weeks ago, and it was not so bad. So I think most people would agree that this MR is quite significant, right? A little bit more on the lateral side, right? Okay. And the posterior leaflet looks small, correct? Oh, that's beautiful. So it's on the lateral side of the. So we were debating versus a Pascal versus a MitraClip. I think maybe we should have MitraClip. So did you do a valve area? We should do a valve area. So that's. So I'd like to show you how he's doing these images. These are very basic planning. And then we'll show you the tricuspid, which is actually torrential. But anyway, let's go to the step. And then you shoot the pulmonary veins, and then we get ready for transeptal. I think you're not on the leaflet tips, are you? No. Get a better leaflet tip. Okay. Yeah, that's 3.4. Nate, did you see that, Nate? The valve is only 3.4. So, yeah. Yeah, but I think you should twist the blue knob slightly on the. Huh? No, but we want to be on the lateral side of the. Okay. Is the valve wide open now? No, you think it's rheumatic disease? And then the TR is torrential, right? So, Gobi, if you agree that we should do the mitral, correct? So we actually came to do the tricuspid, which is very severe. And now we think we should fix the mitral first. Just give one or two views of the tricuspid to show how torrential it is. Oh my God, that's severe TR. And you can see here, if we just do an explain, Bicom explain, and just show how huge the gaps are. Can you show the gaps to people? And then let's do the. Hardly. And you can see that wide gap. And it's actually got worse now again. And this gap is actually getting worse. And we are trying to give some nitro to even bring the gaps down. We're not even sure whether we can get this. So I think we should. We go for the anterior medial. So should we start with the mitral then? Okay. So let me get the transeptal done, and then we can talk about the tricuspid. So let me first. So our goal now is, I think the mitral is significant. We didn't do the pulmonary veins. Can you see? Yeah. What is that? What is it? The severely blunted, right? All right, so we're deciding to most likely use an NT. I wonder whether we should have used just an NT. Yeah, But I'm saying that I wonder whether we should have just done. Nate, do you think you should use? We're using an NT just to give you an idea because the posterior leaflet is short. The question is because the valve radius is borderline, should we use an NT? Okay. Yeah. All right. So let's go in. We're going with the needle. I'm making an extra bend to this. And we decided to go from the left groin. We got access in the left groin because, and we had to give the patient nitro to reduce the TR. So he's in the IV nitro drip. And the reason why we're going from the left groin is because if we want to do tricuspid off label, it's easier to do it from the left groin. So that's why we're doing that. So we're just going to come down. We're coming right down. And I've got a bicable short axis view. And it's still high up. See how I'm coming down there? You see? And you see that's actually good. And you see that's the distance. So he's going to measure the distance and see how it is. And basically, yep. Think so? No, I don't think so. And there's a nice tenting. Advance your probe a little bit. I would advance your probe a little bit. Can you advance your probe? Just a tiny bit inside, yeah. Freeze that. Yes, good. We can see yeah, that's great. Oh, that's wonderful. So you're going to see that? He's measuring the distance. That should be good. So that's enough distance. We need to be 4.5 centimeters away. So we're going to be 4.5 centimeters up. So can you show us where I'm tenting on the bicable view first? Okay. And then the short axis. And so I'm just going to, you want to get the Bovie?
Ready?
No, that's okay. Did I slate to posterior? Is that okay now?
That's fine. Wherever he points to.
That's good. I don't see the bicable properly. Okay, that's probably okay. Oh, you know what? I made a mistake. Oh. Can I see you now? Where we are? I just moved, I think. I think I went too low. No, I think it's good. Let's. Really? Okay. How about this? This is not bad. Yep. Yeah, this is good. 5 is good. Huh? Bicable? You want to be in low on the bicable, right? Yeah, that's good. Did it go jump up? No, it didn't. Okay, good. Okay, good. The Bovie. Yeah, hit it there. Yeah. Keep going. All right, so we're through the septum. We went with the Bovie and went through the septum, and now we're advancing the needle through slowly. Pulling the needle back. Okay, good. So we're in the left atrium. Let me do this. I'll just flush it. Okay. All right, so we're going to do 2 wires. So just to advance this wire. And then 8,000 is fine. So we're giving about 8,000 units per print. Good. 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 Keep going faster. So we usually put 2 wires inside the pulmonary vein. That's in the left pulmonary vein, lower thread. That's great. Advance the sheath inside. Good. Let's put the second wire. Yeah, this is going to be a really just go inside. So we're putting this we usually put 2 wires in the left atrium. Over 1 wire, we advance a pigtail catheter. And the second wire, we want that's great. Just keep it there. All right. So we have 2 now wires inside to hold the groin. And I'm just coming out. So Colleen, get me the pigtail. As you can see, we've got left axis. And the reason why we've done left axis is this patient was not a case for tricuspid trial. And my goal is that we may actually consider, after doing the mitral, consider doing the mitral using the MitraClip on the tricuspid side. And that is actually a little bit more challenging. And that's why we are going from the left groin, because it gives you better access to the right atrium. Tricuspid valve. So okay, yeah. Now advance it. Yes. So we're advancing the pigtail. Can somebody make it bigger for me, this screen? Can somebody get this closer to me?
Yeah, you know what? Can I make some adjustments?
Yeah.
Come down, Dr. Gabriel, sorry. I just need to see the.
Yeah.
Section.
Yeah.
And then towards that, hands a little bit.
No. Towards the head. Yeah.
There you go. Yeah.
Okay. So the pigtails in the left atrium are in the pulmonary vein. And we're going to measure pressures from there. And let's see what the left atrial pressure is like. So our LA pressure is not so high. It's 13. So that's good. And then push this. Now we're going to dilate the vein. Go. Keep going. Go next. Good. Okay. Now hold the groin. Hold the groin. But I let this out. All right, let's get the guide catheter. So we're going to get the guide catheter in. Okay. We have a super stiff wire in the left atrium inside. Okay, now advance that, please. Okay. Okay, keep going. So she's advancing the guide slowly through. Andy, can you show the images, please? We're trying to go across the septum. Show us the septum. So we'd like to look by septal view where we are. And we don't need that much of fluoro to show it going through. Can you make echo large and fluoro small? Pedro, make echo large. Throughout the case, we'll focus on echo and fluoro small. Okay. All right, the guide's in. Okay. There's a little bit of pressure guide. Can I get the? Yeah, good. So now we're going to put it on the stand, and we got about 2 centimeters of guide in at least, right? The stand has to go backwards. Yes. Okay. We got 2 centimeters in. Good. So we have 2 centimeters of guide in. So let's. So what we're going to do is get the guide ready. I'm just worried about the valve area being a little small. Okay, good. Gently aspirate. Okay, so I'm just going to get the dilator back. Now put the pulmonary veins back. Yes. And aspirate slowly. Yes, very gentle. Not too much. Just almost gravity. Not that. That's too much. Just okay. Good. Pull it back. No, pull it back. Pull it back. More. And I'll give it back. Give back the blood. Good. Excellent. Good, one more. Good. Give one more. Great. That's good. First year cardiology fellow doing MitraClip. Not even 1 month into fellowship. A week into fellowship. Okay. Yes. And then flush flush. Just keep flushing over there. Just yeah. Good. That's it. And then you see the blue line to blue line. They match each other. Yeah. Okay. You can start advancing this catheter. Yeah. Wait a second. Let me get this. Just advance it. Can you see the guide, please? Sorry. Okay. Keep coming out. Okay. I can't see the guide. Okay, good. Go. Keep going. Go. Slowly go. Just a little bit more. Go. Just a tiny bit more to the marker. Keep going. Keep going more. Stop. That's it. Very good. All right. So, yeah. So I'll just pull it back a little bit. And then I cleared it. Good. Now I'm just going to advance it a little bit forward. Good. You see how the clip is coming? Now a little bit of a turn can you give? Just tiny bit of 1/4 turn. Just a little bit to look at it going down. Coming down straight down. Go. More. That's great. A little bit more. See how it's going to the valve? A little bit more. Go. More. That's great. Stop there. Let's orient myself. I wouldn't do bike this thing red yet. Can you just play with the regular bicon for the first few minutes? Yeah. Okay, I like that, but it's a little lateral side, but it's actually diving quite nicely, right? It's a nice position, actually. What do you think? What the color jet? Okay. I'm coming a little bit more medial. Okay, and I'm just going to open the clip. Okay, good. That's pretty nice. Yeah. I wish I'd used an NT, yeah. That looks nice, right? Where's the guide? Now we're going to see the dot and things like that. So that's for dot is posterior. Blue is anterior. Now the only thing I need to know is whether we are too, I just brought it down. See how it's diving medially, right? Okay, that's up and down. The color, I want to make sure that I'm in that jet. I just moved it counterclockwise, clockwise. Can you do a real color of this thing? I really want to see. Yeah. Yeah, that's nice. I think that's where we want to be, right? You want to decrease the tidal volume, which is okay. Okay. And explain that. Okay. So put color there. What do you think, Nate? Should we move a little bit more middle? We can. Yeah, but remember the jet was initially a bit on the lateral side. I think we should go down and we can always move, right? Yeah. I'm going to down, closing the clip. And I'm just going to go down. Now let's first orient. Okay, you get your view. Now put color there. Okay, so we are two lateral, right? Now we are free, right? See that? Now I'm really centered. You see that, guys? I like that. Now I'm going to open the clip. Okay. Let's do the color. Make sure that I'm in the where I want to be. So I think that's where we want to be, right? It's a one clip case. So shall I bring it up? Just do you want a quick 3D? Yeah, I like to do a quick 3D. The leaflet's already grasping, which I like. Well, the anterior leaflet's on. You see that? See? And then we're just going to get the posterior on. Oh, that looks very nice. So the orientation is perfect. So see how the anterior is on? And I'm just going to say I'm going to go clockwise. And I'm going more clockwise. Hold it like this for you, Mara. Very good. All right. So I think both leaflets are on. I actually want to go more from posterior. Hold it like that. And then I can just drop both the grippers. So we've got both leaflets in. Let's see the 3D end face. Well, the orientation is perfect, right? So the question is, should we take more posterior in? I actually would like to get more posterior in. You agree? So what I'm going to do is I'm going to close a little bit the clip. And then I'm going to do clockwise on the guide. Clockwise on the guide like that. Hold it like this. Okay, good. I'm going to pull the dot back. This is calling optimization of the and I see a lot of posterior in. And I can dive and drop it again. And I'll just release this. So do you see how I got a little, you think anterior is less? Anterior looks great, by the way. Posterior is now better, right? I can check, right? And I also think anterior never came out. It was always in. So I actually liked, if it's okay, I want to close the clip, but I want to see the orientation first. Can you show us the LA pressure also? Okay. On one side, show LA pressures. Pedro, can you show LA pressures here? So orientation looks great. Yeah, that's great, Pedro. All right. So now we're going to close. And we're closing the clip and we're going to go. Let's go. Do you want to go and show? I want to close it on explain. Yes. Yes, yes. I'm closing very slowly. There's no urgency because you don't want the leaflets to come out. And you're watching the LA pressure. It's coming down a little bit by a time. And there's a smoke appearing in the left atrium. You see that? And that's usually when the MR gets less. And I'm actually pulling in the leaflets a lot. And the LA pressure, to me, the V wave became less. Okay, and now let's look at it. Let's look at the color. It's much less, right? But there is a jet on by the side, but I think we should leave it where it is, right? Yeah. Yeah, LA pressure is 11. So it didn't go up. Now let's do all the orientation. It looks very nice. Grover, those images are great. Yeah, and that's a commissural jet. See on the side, the medial jet. I'm just going to leave it there. And there's a tiny jet there, but I think we never lost orientation, right? We were sometimes we ought to make sure that we look at. We can open a gate, but I don't think we should, right? And let's look at the pulmonary vein flow. His blood pressure on the lower side. Okay. And you want to measure the gradient? A little bit more upright. Still blunted, but a little bit more upright. If you didn't get the pulmonary vein right side, okay, that's good. You got the right one. All right. And the gradient we haven't measured that, right? That's going to be the key to keep this clip. Okay, good. So with a heart rate of quite a lot of, the heart rate is pretty fast. The heart rate is 112, right? So with a heart rate of 12, if we're gradient of 3 is actually quite good. Yeah. I think that's acceptable, right? So we obviously can't put many more clips anymore. It's a smaller valve. That's actually the limitation. But it looks nice. The clip is quite V'd. See, this is in fluoro. You can actually see the clip quite closed. I'm actually going to tighten it up a little bit more if I can. It's jumping on the weird on that anterior leaflet, right? No, there it is. Exactly at the leaflet, it's okay. See how it's pulled in? Yeah. That's outside. There's a lot of leaflet inside. All right. I like that. Okay. I'm just going to deploy. Ready? Okay. So deployed. Colin, do you want to do it? Okay. Try to open the clip. Yeah. Good.
Floppy. And then positive side.
Yeah.
Of which is this.
Yeah.
Okay.
Good. You see how the clip opens up a little bit because I think there's so much tension. Do you think we should let it go? But I think it's okay to have the calcium nodule. It's okay. The leaflet, the posterior leaflet was not moving at all. The anterior leaflet, even when I grabbed it and pushed it the other side. Yeah. Okay. So yes.
It's closed tight. I'm opening.
Yes. Positive side of neutral.
Floppy. Positive.
Yeah.
Okay.
That's all right. Okay, good. Now let's open this up. Good. Ready? Good. So I think once we get this, we're going to check the lights on to this.
I'll let go.
Okay, it's good. You keep pressing it. Okay. Okay. You want to do you want to flux it now?
Yep. This one.
Yeah.
This one.
Okay.
Port.
Yep. So that's the lock line. Yeah, the MR is on the medial side. I can't do anything to that. Okay, good. Okay, good. Just tighten it up. And then come to 0. Good. Neutral. Good.
Neutral. Positive
Good.
side.
No, that's right. Take this out.
Okay. In.
Yep. Yeah. Okay, good. Good. 8 times.
7, 8.
8. But that MR appeared in a new area, right? We didn't have that before, but it's okay. The clip is done, deployed, the clip is stable. Want to have a look at it? Okay. Just have a look, one look at color. Yes, sure. Okay. Well, we're not going to do any more clips anyway, so it doesn't matter actually. Yeah. We measure that. No. Top. Okay. Just gentle, very gentle, even less than that. Yeah, so there's only that medial jet which came new, but the central jet is completely gone. There's a tiny left whiff. Okay, that's good. Aspirate. All right, the pulmonary vein is slightly improved. Okay. All right, so push it back. Okay, good. All right, so now I'm going to pull the guide back, and now we're going to deal with we dealt with the mitral. I think it's safe to now look at the tricuspid now. Okay, Pull it back. Good. All right. So I'm pulling the guide back. And then we're going to go negative on the guide. And let's look at the tricuspid now. Oh, yeah, sure. But it's very small. Yeah, yeah, sure. Okay, good. So let's now look at the tricuspid and see what we can see. As you can see, the RV is bigger than the LV, right? And that's always a sign. And the septum is very flat. Tells you, look at it, look how bad the tricuspid is. Oh my gosh. That's torrential. And she was excluded from every trial. So she has really no hope. So we have to do something for her. Oh my God. So that's the RV inflow outflow view. I think you should see that leaflet, there's a big gap there. I think we should go with the XT. I don't want to go next to W. XT. So we're going to try a wide clip. And you agree that we should take a try, Nate? All right. So let's get one deep transgastric view. What's up? Yeah. Yeah, same thing. You could do mitral tricuspid, same thing. Yeah, it's very different. It'll be harder for me to do it from the side. So they were asking me a question, the text were asking me, am I going to use the same guide? Yes, the thing is that it's harder to do a off-label tricuspid with the MitraClip with this guide. We're used to using the TriClip system, but that's in a clinical trial. She was excluded from the study because the gaps were so large, but she's almost a compassionate use. So we're trying to get a reasonable view of the tricuspid valve. And we're not even sure whether it's even possible. But since we are here, we think it's worth a try. Oh, you want to go XTW? You will also. Okay, because I'm just now not even seeing any area where I can grasp. At one point, I found something good, right? How much of nitro is he on now? That's a nice picture he's getting. Yeah, that's actually very good. Now put the color there. See if I can get that edge in, pull something inside. Okay, that's fine. Gabe, there was Andrew, you had got better pictures than that. Maybe that's what it is. I mean, I don't know how I'm going to pull that in. If I'm going towards a commission, then I should use XT. Because then I'll get caught in the cords. And you think that I won't get caught in the cords. So, do you want to go MPR and see what it's like at that area? Yeah. There's no way I can go anyone higher than that. No, it's going to help me to bring the other two to the anterior and septal more middle in the middle. That's all I'm going to do. Yes. And then try to pull the septal and anterior together to go. I was going to use XT, but he wants me to do XTW. I think the reason why I want to go XT is you can't even see the septal leaflet. Yeah, you see how it's pulled. So that little bit of commissional, You see that there's a big cord there, though. Yes. Yeah, because the gap. Yeah. Okay. So we're going to use an X. You can see there's a terrible gap. So we're just going to go to the edge, and we're going to zip and go through forward. We don't know whether it's possible, but we're going to try. So while they're getting ready, Nate, so you want me to counterclockwise 90 off, right? Yeah. Not the clockwise. You can. Let's keep it. Huh? So we have Gabe and Colleen, well, most of the time drunk at work. So they come drinking tequila to work to keep going. So actually, what I would like you to do while he's setting up the clip, I want you to show some basic imaging to people how you do it. And actually, this is a very nice view to show teaching of where you are oriented. So describe every view to the audience. See that? So that would be in cloud view. That is the tricuspid septal leaflet. That's the anterior leaflet. Got it? And then this is the short axis. This side is anterior, that side is septal, and the top left is posterior. Got it? So anterior, posterior, septal. And that's the 3D and face. Posterior, got it? So we want to get between the septal and anterior. See? So it goes to more to the commissure. See the red line? And that's posterior. That's correct. And the goal is to bring that in so that we can get the septal and anterior more close together. If we can get septal and anterior together, that will help the patient a lot itself. Even though the jet is not so much there, and the jet is more in the center, but we will not be able to get that, and it'll stabilize the annulus. So we're getting everything ready, and we are going to use this, and there's a little bit of a challenge when you do the MitraClip system for the tricuspid side. We have to key slightly differently. It's not working now? So we're just getting the clip ready. So you want me to be keyed up like that, Nate? You want me to be keyed up, Nate, like that? Yeah, just key it here and turn your guide. Yeah. 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 So I'm going to go, I'm going to miskey like 90 degrees off like this. Yeah. So it's very important to miskey this. Otherwise, and that's how you want me to do it? Okay, good. You're going to get it. Very nice. Okay. All right. Come, Gabe. So you're going to use the flush again. Okay. Okay. So the way I'm going is, Nate, you want me to go 90 degrees off like this? So it should be 90 degrees off, right? And it should be a key there, right? Yeah, I got it. So we miskeyed by 90 degrees. And you're going down on the nitro rib? Okay, that's fine. Okay, that's fine. Want me to come out? Yeah, what he's getting is he's controlling the pressure now. Okay. Yeah. And I'm very negative on the guide. Is that okay? So counterclockwise. Right there. Are they now? You want the minus off? That's true. So using the A knob to come down on the valve. Let's try some more A knob. That's good, eh? And let me just straddle a little more. Not yet. Okay, I didn't see it. So I'm going to give a little bit of A knob to make it horizontal. Okay, that's good. And then I'm just going to see that it has to go towards the valve. And now I think I'm in a nice position. Yep. So this is a very different system. Hey, thanks for helping out. Because I'm not used to this. Okay, so there you can see the clip is towards the anterior leaflet. So if you clockwise your guide, slowly, and you see what happens. Clock it, go. Very good. See how it's going middle? Go a little bit more. Great, awesome. And yeah, that's the right position. So we're in good position. So now we can come back with the whole system and be in the septal position. Let me see counterclockwise a guide. Now you see how it's in septal, counterclockwise more. You just see the middle. That's good. Yeah, you see how the tip is. So a little bit more counterclockwise. I think we're in a good position. I think we should open the clip here, right? The issue is whether I should go in and then like that and go. Therefore, I'll get a wall hugger. Let's want a wall hugger. You okay with that? All right. Okay. Okay. So we're nice. I think our orientation is getting good. And I'm just going to test the lock and thing. So the dot is septal and the blue is anterior. Okay. Good. So I think we're a little bit too. I want to give a little bit more A. That drove it a little bit there. And I can just move it. You have to advance your probe a tiny bit more. Okay. So is this good or not? Is this good for you? So do you like this? Do you how do you want to orient the clip? I would just do three like MPR. Yeah, do MPR. So MPR is a term called multi-projection reconstruction imaging. Reconstruction. So what he's doing is he's counterclockwise on the guide. Yeah. Yeah. Go slightly more. That's good. I like that. Very good. Yeah, stay there. That's good. Yeah, I'm going to come down so that you can see things. I think the orientation is very good.
Yeah.
Counterclockwise more to the guide. Yeah. I wonder whether the gap is too big there, or should I try to? I mean, if I can grasp there, it'll be fantastic. Okay, so I'm going to come to the red area. A little bit counterclockwise, right? And then a little bit clockwise. Yeah, that's good. I like that. A lot of finesse in tricuspid. Yes. I've checked my grippers. So the dot is, yeah. So let's glow down. I'm going to close the clip. Clockwise your guide a little bit. Yeah, a little bit. I can go in the center. Yep. Already bouncing. I think I've already got it. And I think I've got anterior too. Now, septum slipped out. But if I slip, okay. Okay, I'm going to drop independent grippers. So I'm going to do dot. Yeah, I've got septal, and I'm just going to put anterior. See that? I'm not even getting anterior. Okay. All right. I thought I had anterior in. No? Yeah, so more inside the valve. It's actually caught on the anterior is caught. Yeah, I know. I'm looks like I'm very. Yeah, but look at this. I really got the leaflets. Right? But just think of how I've got them. We never expected to get this. Just put it like this. It might be worth the grasp here. I don't know. It looks like I've got both. Oh no, anterior came. You're right. As I got the postseptal, okay, it came off. It's all right. So let's pull the blue off. All right, I'm coming back. Counter. Okay. Okay. I like this. Just put it like this for me. No. Yeah. I'm trying to do independent grippers. Okay, so all right. So you want me to come out? This is fine. Okay, but the issue is that if I take off a knob, okay, so I need to come back down. I don't know I don't know why it's getting stuck somewhere. Yeah, that's what I'm saying. I had the septal leaflet. See? Is it? Why did it do this? Let your hand go. Okay, got it. Now it's got on the other one. I don't like this. Okay, so now I can go in the middle and slide more anterior. Good. This one translated on fluoro, and I can take off. Right? And the orientation is okay? Okay, let me see. Is it knuckling? You want to give me a dedicated view, or you want to give me the magnify that? Huh? Okay, so just take septal. I can't see. The anterior looks good too. No. The question is, have I got anterior? All right, shall we close? I don't think so. I didn't have anterior. I knew it. Remember, I told you I did not have anterior. Okay, so the anterior is the blue. Looks like it's in, right? I got both leaflets. Yep, I got it. So we got exactly where we wanted it. Okay, this is beautiful. So let's talk about this case. So how we can show magnified for the audience how nicely we've grasped the anterior and septal. Yes. So you can see over here the lower, look, that's the anterior leaflet. Posterior septal is right inside. Right? Yes, I know that. Yeah. And TR jet is less also. No, I actually am not recording. Our pressure is 9. It's so I think we should use this and I want to put another clip close to the anterior. So I'm going to deploy that. Is that okay with you guys? Yeah. Pedro, are we doing well with time?
Yeah.
Yeah, we done one clip. We already done mitral. Now we're doing tricuspid. We're going to put 2 more clips on tricuspid. You want XTW? Okay. So anyway, so let's deploy this. Yeah. So tricuspids can be tricky. So we got it in a nice view, right? All right. So you want to tighten it up? Did you see what she's doing? She's tightening it up. And the blood pressure is better now. Okay, lock it. Good.
Open it.
Yep.
Copy neutral.
Okay.
Side.
Good.
Okay.
All right. Now take the.
Take the pin out.
No. This one.
Oh, right.
Yeah. Okay. Good. So yeah. Okay. Good. Here go. Nice anterior. So we use the independent grippers to grasp the anterior and the septal, which I think was very helpful, and to slowly pull it in. And that was our original goal, just to get that first. And that as soon as you start bringing the anterior and septal together, the size improves. So let's just pull that away. Good. Yep. And that's where we wanted to be. I knew that's far away, but okay, good. Yeah, and so we want to go right horizontal anterior there. That's why we want to do ST, and then we'll think of the going posterior, right? Yeah. Yeah, 3 and 9. Yeah, right, just there. Yes. There, just there. Yes, we want to go septal anterior. There's a real estate there, and there's a gap there, and the septal and anterior leaflet both look good. So we can just go there. Yeah, look, lock it first, close it, tighten it. My trick, tighten it up fully.
I have the pin out.
Okay.
I have the pin out.
Oh, you have the pin out
Yeah.
already. Okay, shit. Okay. All right, sorry. Okay.
See it?
Okay, good. Yeah. Yep. 8. Yep. Pull that back. Good. And then pull that back to 2. So the clip is deployed. The clip is in stable position. It's not moving. You see that? So let's go back. So, Nate, do you want me to counterclockwise the guide back to its normal position while I take it out? So I'm getting back the anterior off. Just want to make sure that. Yeah, please. You want to. Okay, good.
She hooked up for us.
Yeah, she's going to be aspirating. Okay. Good. Okay. More close. Yeah, I'm just getting out this clip without any problem. We came out, aspirate. Nice. Put it back to normal. Give it back the blood. And give it back. Okay, good. Yep. Good. Okay, nice. All right. So you understood that model, right? So we are between the septal and anterior, closer to the commissure. Now we're going to go septal and anterior, just lateral to that, on the middle of the septal and anterior, correct? And that's how we'll keep on bringing the 2 leaflets together, and that will reduce the TR by itself. Just bringing the septal and anterior together, it's a lot help because it stabilizes the annulus. It prevents the annulus from dilating. Which one? So this is actually one of our very challenging cases, which doing a mitral and then doing a tricuspid, which was impossible to do. We've actually got till now quite well. Pedro, are you okay? You know, Samir, Dr. Mehta wanted me to do something interesting on the last day. So I actually thought of this case. I never thought I would have to do a mitral too. And because the patient is not in a trial, so we don't even have the tricuspid available. We have to use the mitral clip and manipulate it towards the tricuspid side. And it's actually a good teaching case to show how people can use the MitraClip on the tricuspid side. The actual clip itself, the 4 clips are in the TriClip. The only difference is that the TriClip delivery system is suited for tricuspid. That's the only difference. So the guide catheter and the knobs are slightly different. So those are the two, but the actual implant is the same. So we're going to do the same procedure over here now for this next clip. And I think if we can get one to the anterior, then we are in good shape. I mean, if we can stabilize the whole anterior and septal, it'll be a lot for this patient. Good. All right. Colin, let's get that. Thank you. Get the flush ready. Flush. All right, so Nate, I'm going to turn it like this, Nate.
I'll trade you.
So the trick is that the blue line and the blue line, they have to be keyed by 90 degrees off. Do you see that? So I'm going to do 90 degrees off. And I'm going to miskey it by 90 degrees. See that? And 90 degrees off. See that? And that's the trick of how you do this case. Yeah. Should I just go in now and just turn it upside down or sure? Nearly down. Can you see? Yeah, you can see the clip. That's good. I'm just going to come back. As far back, but the clip is okay. Good. Yeah, like that. So I just use the A knob. And I see where we are. A little bit more A. So I just have to be underneath, so I have to move it back. See that? And then I'm going to counterclockwise the guide. So see the guide, that's too much septal, right? Septal is clockwise, counterclockwise is center. So you have to bring it that way. And then we can see we're here. So we have to bring it a little bit more back and then take off a bit away. Hold that there. And then take off a little A. How about that? Looks nicer, right?
Right there.
Can you see where we are by? Gap is much smaller there, right? Already. Yeah, that's it. That's it. You like that? All right, so let's open the clip now. Okay. And then I'm just going to pull the clippers back. And I'm just you may ask me, how am I managing to know that? Just by fluoro, if you can see the arms are aligned, you know that you are well aligned. So I'm just doing that. So I like that position. I think I can come back a tiny bit more with the whole system and then take a little bit A off. What do you think? And that allows me to be more parallel. Right? Yeah. So let's do that. So the blue is anterior, post anterior. This the dot is septal. Okay, good. So now let's look at the. Yeah, first look at the inflow outflow, and see whether we are too close or we should move up a little bit more far. I think we should. It's actually a nice position. There is a gap. You want to put some color there? Yeah. And we can go even further medial if we want. I just can't see the septal and in the. Yeah, that's actually nice. I think we can come back even a little bit more away from the clip. First clip, right? I mean, there's two ways to do that. We can, or in this clip here. So I just move the whole system back, and now advance, and then, yeah, that's actually not bad, right? So I think we should do that, right? How would like that? Okay. So we can take off a little bit of A and dash. It's more parallel, and then I can now. Do you want to see the orientation by? Do you want to see the orientation again? Okay. Okay. Okay, so now this looks tricky. Good. So that's the commercial line. Good. The green is exactly commercial line. So now you can do the blue up and see where we are. Or I can put. Yes, I do. And I'm closing. Yep. And it's not bad. Right? Yep. All right. So let's close the clip. All right. And I'm going to be a tiny bit away again, so I can get more purchase. And I'm going to go in slowly. And I'm going to open the clip. And I actually want to pull back a little bit. Yeah, I did. So I need to counterclockwise a little bit. That's right. Good. Like that position, much better, right? And hold this, please. Hold this. Yes, good. Let's open the clip completely. And we moved quite a lot away. The question is, should we? I think I should clop the clip a little bit, right? Okay. Okay. So now let me orient. I'll tell you what I should do. I should come back. See, I clocked it a little bit. I think I should try to get septal first, right? Okay, so yes, I can see that. Yeah. Okay, got both. Question is, I missed the anterior. Do independent? Okay, like this. Can you show me where I am? Yeah, I did counter it. I think I need to clock it. So should I just go a little bit more in the closer to the other clip? Yeah, yeah. Okay, so hold it like this. Did I? But I definitely got septal. Actually, I got both. I actually got both. That's really nice. This is a great case. I mean, I never thought I'd get this. Wow, looks beautiful, right? So that's, yeah, that's fine. So Ann is bothering me about ACT and I'm not listening to her. Very nice tissue. So I think this is a time when we can actually focus on real three. Yeah, well, look at the leaflet looks really nicely in, tied in. Yeah, that's right. Let's go. Yeah, that's right. Oh, look at that. The TR is so much less. Wow, that's actually quite impressive. Yes, torrential. So do you want to show the deep transgastric ones for the, it'll be nice for you to teach the audience. I think this is one of the toughest cases I've done here. A mitral and a tricuspid clip, which was not even approved because it was too high, difficult to do. We got two nice clips in. But in tricuspid, as he's beautifully showing you, he's showing each leaflet separately. I think you're showing the first, the shaft should be seen. So you can see the anterior in, very nice. And you can see there, very good. So we're happy with that. Now let's do the deep transgastric. And if that's good, we're going to deploy. And look how beautiful that is. That is a beautiful picture to show. Nate, where are you going? In case you need it. Okay. You see if you have enough clips. Okay. Good. So you can see how nicely we've closed up the gap. Whole septal anterior is taken over. And I don't, this is really good, actually. I don't even think we should do any, because you see, that's a central jet. And I don't want to boot one within septal, right? We've taken care of the entire septal and anterior leaflet and only left with gap between posterior and anterior. And I have a feeling if we try to go something there, we might cause stenosis. And this, we had enough gap. What do you think, Mara? You're a first year fellow. You should say something. You should say, I concur. No, I concur. Haven't you seen the movie Catch Me If You Can? You say no, you just said, I concur. I concur. Exactly. You're a first year fellow. You're supposed to say, I concur. That's right. Right. We just have left the cancer. Let's look at color there. I mean, do you think we could put another one very close to? No, but what about just close to the middle and on the anterior side? Okay. So anyway, let's deploy this, right? We have a good, you see, agree with that? I concur. That's right. That's very good. It's very good that you come and you. So basically, what we're doing is we're deploying this clip. Okay. So what I'll do is you can come here. Come. You want to do it? You come this side. So I'm going to get you a view where you can see the clip clearly. And for the audience, I'm actually teaching a first-year cardio fellow how to deploy a TriClip. And the first thing you want to show that the clip is, because Colleen was not very helpful. Okay. So you can see the clips are parallel to each other. Okay. Hold this with the right hand. Okay.
Right hand.
No, say left hand. Okay, good. And tighten the clip a little bit. Okay, good, very good. Make sure this doesn't rotate. Go. Yeah. Good.
Oh, there we go.
Good. Excellent. You got it.
Okay.
Now try to open it. Keep it. And look and watch fluoro and see if it's opening up. Keep going. Keep going. So you can guys just show fluoro. Keep going. You can show fluoro in the left corner, Pedro. Keep going. Not opening. Okay. That you opened it a little bit.
I did.
Tighten it up. And open it up now. Good. Very good. Excellent. It is very loose. See, that's very squeaky loose. And then all you do is positive side on neutral. Okay.
Okay.
Then I'm going to take this cap off. And you hold that still. Okay. Now try to take this rubber seal off. Let your hand go. Okay. Now take these two or take this off. Yep. Take that off. Now each of these take them off. Good. Separately. And now try to floss them. So pull one. Just pull it a little bit. Up the other one. Pull the other one now. Let go. Good. Excellent. Now start pulling this other one out. Yeah. Let this other one go. And just keep pulling. Yeah. Go. Completely out. Right. Very good. Once you see blood, it means you can come out fast. Good. Good. Now you're going to tighten the clip again. The clip opened up a tiny bit. It should be okay, right? And then go to neutral. Go to this is neutral. No, this is not it. This is neutral. Good. Now you're going to take this off. And turn this 5 times. The screw comes up. Now turn this 8 times counterclockwise. 8 times. No, 1. 2. No, 2. See, right here is 2.
Okay.
Right here is 3. Okay. 4.
5.
6. 7. 8. Now gently pull this back. No, this one. Gentle. Good. Great. Pull these 2 together.
Together?
Yeah, these 2 plastics together. Great. You deploy the clip. Okay, that's great. It's staying very well. And they're nice and parallel to each other. I want to get this on the other side. Okay, good. Take this away. Okay, good. Lock it. So we're taking out the system. We're deciding whether we should do any more clips. And I actually honestly think we should not. We've definitely reduced the MR significantly. It was torrential. And now we're left with just a small jet posteriorly. We should measure the gradients and then make a decision as to whether we need anything more. This is actually a huge save for this patient. Her blood pressure is now 120 by 60. While we were doing the procedure on a nitro drip, her blood pressure before was 90 by 70. Can you show the pressure lines once? Actually, we don't. And so the transcal is 3, so that's a lot. Actually, we should not exceed that. For a tricuspid, if anything greater than 4 is severe tricuspid stenosis. So I think we reduced it to moderate. Our blood pressure is at 120/63 is only moderate TR. You got a very good anterior bridge. And let's just show a couple of images while for the audience to see this. Look at that jet. And it would be nice to show the before and after, but itself you can just show this. It'll be great. So what I would like you to do is show the deep transgastric, then show the RV inflow view and this thing, and that's it. And then we're done over here. The RA pressure. And now it's left to right. So, and the RA pressure has gone down. It was actually, we started with the RA pressure of 10 or 12. Now the RA pressure is 9 with a blood pressure of 135/66. So the blood pressure has gone up, but the RA pressure has come down. And you can see how it is. We had a wide valve. Show that beautiful picture where you see that the most of the anterior put together. And usually that's all I do. And usually what will happen is it stabilizes the anterior septal and it prevents it from dilating. So we're done over here. And so we're going to straighten out the guide while you're doing everything over here. Okay. So, Han, have you measured the ACT? Measure this was the final RA pressure. Was it? Measure RA, call it RA pressure. RA pressure is 8. So the RA pressure is 8. We started with 11 RA pressure, and now it's 8 with the blood pressure, which is significantly increased. Okay. So there's only some oozing a little bit. Can we get a figure of 8 stitch? So there is actually a very minimal bleeding now. We just did a single perclose. Look at that jet. It's only on a small side. That's pre? That's pre, and you should show that now. So that's how we started. And I think you should show now what it looks like in the 0 degree view. That was what we started with in RV outflow, inflow. And that's for the audience. And now you can show them what it's now. Well, I would do 0 first. Oh, you're just taking pictures. Look at that. Isn't that an amazing difference? I'm just doing a figure of 8 stitch. And we're not ending the case now. We're going to say a summary of a few words, what we're going to do. Pedro, are you here on me? Pedro?
Yeah, Dr. Crom here.
Yeah, we're going to almost finish, but we're going to summarize everything. I want you to show he's showing the images, the final images, while I just close the groin with 1 figure of 8 stitch. I would actually, before I say anything, I want to first to Medstream, I first want to acknowledge and thank everybody in Las Robles, starting from the service line director and everybody in this hospital to participate in this Medstream. It has been a lot of hard work for us, that every Wednesday we would have to find a case and work late. Usually, Colleen's out drinking at this time, right? But you're not today. So, Colleen, thank you. Thank you. Marwa, it's very good. This is the way you start your fellowship. You love it? Okay, that's good. You concur. Andrew, phenomenal job in taking us through. I do want to acknowledge Nate for being here for us. You've always been there with me. I want Gabriel is already out of there drinking margaritas. That's fine. Jose, thank you. And before that, I also want to acknowledge and thank Samin Mehta, Samin Sharma, Greg Stone, and Mike Gibson for this phenomenal opportunity for people to learn through these real-time live cases where nothing is scripted and we are allowed to freely show cases. And this is a case we started from beginning to end, initially planning to do just a TriClip, just a tricuspid ray, but landed up doing a MitraClip and then putting 2 clips on the tricuspid side off-label. Just to end, the final pictures are on the screen to show a beautiful picture of the MitraClip on one side, and he's trying to show at the same time the tricuspid. I think you should rotate the images if you want to show both. Yes, that's right. So the mitral on the right side, the left side, and the tricuspid. But the reason why the tricuspid clips are not seen very well is because it's a little bit deeper, but you can see them on a shade. And this is a patient who's now left with only moderate tricuspid regurg and mild to moderate MIT MR when started with torrential tricuspid regurgitation. Thank you very much. And the RA pressure did diminish, and the blood pressure now in the patient is ranging between 130 by 60 and with the heart rate still about 150. So thanks a lot. So we did that in time.
Thank you.
Thank you. Yeah.